to introduce to you our next speaker, who's Dr. Carine Prinsloo from South Africa. Dr. Prinsloo, are you there?
Hi, I'm here. Yes, I'm just waiting that Ms. Lena just stop her sharing her screen. Okay, now I can share my screen. Just want to make sure, is it sharing yet?
Yep, we've got that.
And can you hear me?
Yes.
Okay. I just want to give some background about me. I did my PhD. I completed it 2 years ago, and I was working in one of the biggest private hospitals in South Africa for nearly 25 years. Before I went and worked at the University of UNISA. On the screen you can see a nice photo of the university, and my passion is about leadership, and I was working in the outreach department, so I'm going to talk about self-leadership in the outreach service. Just the layout of the presentation is I'm going to give an overview of what is critical care outreach services, and then I'm also going to give an overview of what is self-leadership, and then my research and a discussion of the findings and conclusion. Okay. Critical care outreach is a service that was implemented after they have discovered, not discovered, but noticed that nurses delay or miss patient deterioration, and this contributed to serious adverse events in general wards that could lead to patients being unplanned transfer to the ICU or a prolonged stay in the hospital. So, and research has indicated that there's a lot of abnormal vital data in the patient's records that showed the patient was deteriorating before he was transferred to ICU. And this made that they decided to implement this critical care outreach service, and it was globally implemented already in 1990. It started in Australia, and then it went England, America, Canada, New Zealand, and South Africa. South Africa implemented it in 2007, and I joined the outreach team in 2009. And I was there until I left to join UNISA. Okay, outreach, the definition is critical care outreach services is offer intensive care skills to patients with or at risk of critical illness, receiving care in locations outside of ICU. And the objectives of the critical care outreach service, I'm just going to name it as outreach, is preventing critical illness to the patients, to avert or timely admission to a higher level of care, and then enable discharge from ICU. Sometimes your ICU is full and you need to transfer a patient that's not less ill than the one that's waiting for a bed to the general ward. So the outreach helped with enabled the discharge patients from ICU, and then it also is there to empower the ward staff. Okay, these diverse modules that was implemented globally, some were nurse-led, some were physician-led, and they all had different names, like the critical care outreach service, outreach teams, medical emergency team, rapid response systems, patient at risk teams. That was all the different names. There's no same module developed for outreach. Each country developed its own way of implementing these outreach services, but they all had the same thing, same in common, is that they had a track and trigger system or a calling criteria that activated the outreach service, the outreach team, actually, not the outreach service, the outreach team. And these criteria was early warning systems, scores, and modified early warning scores. That was the main two scores. And these are vital data. For each vital data that they do with the, take the patient's vital data, a score has been given to the patient's blood pressure, for example, for his pulse, his respiration, and this score is accumulated, and this score will indicate if the patient is at risk of deteriorating, and that will trigger the calling, the activation of the outreach team. In South Africa, we were nurse-led. All the nurses that was part of the outreach team that was been called, I call it outreach experts. They were ICU, they were registered nurses, and they were ICU trained or trauma trained. So they have the extra qualifications. So we took our ICU knowledge to the wards to help these patients that's at risk of deteriorating. And we use the MUSE as the scoring criteria to call, to activate the outreach team. So, and now I will tell you about self-leadership. And Nack and Houghton, they, like the seminal thinkers about self-leadership, have this definition of self-leadership as the process through which individuals control their own behavior, influencing and leading themselves through the use of specific sets of behavior and cognitive strategies. Now, amongst these strategies is behavior-focused strategies that revolves in self-observation, self-goal setting, self-cueing, self-reward, self-correction, correcting feedback. So that is all aimed at to change your behavior to do the proper thing that is what you require to do. And then there's natural reward strategies that refer to the employees' positive views of the task which needs to be completed. So to create a task that's normally general and a routine task, you create it in a positive way. You make it for your enjoyment. And this task is also for its own values that you do the task. It's not any remuneration of it won't influence you to do this task. So it's developing a positive side of this task that you need to do. And then the constructive thought patterns is to change disbelief, dysfunctional beliefs and attitudes amongst employees. And they need to replace this dysfunctional thoughts with positive thoughts. And you can also do self-talk. You reprimand, I know all of us, if you do something that you didn't need to do, you will reprimand you in your mind about not doing it. And also when you do something very good, it's very uplifting. So you congratulate yourself. That's all part of your constructive thought patterns that you get. The reason why I did this research was that I've noticed, although the outreach was implemented in the hospital, and this was also evidenced by research publications, is that the nurses were hesitant to call the outreach team. They sometimes didn't know how to calculate the mutes. They didn't have the adequate knowledge about this. And then also patients were transferred to ICU and without calling the outreach team before the time. And that was all that was noticed. And that's how I started to thinking, what is nurses' experiences of their self-leadership in the private hospital where I started it. I'm going to talk on this webinar about one part of my research, and I think full part of the research. It was part of my PhD, and my PhD was a sequential exploratory descriptive mixed method research, and it had 4 phases, and I'm just going to do one phase of this 4 phases. Each phase had its own objective. So this is a qualitative approach that was linked to this phase where I did the exploratory, descriptive, contextual design. And during this design, I used focus group discussions. I had 8 focus group discussions. In South Africa, we've got 3 different nurse categories, registered professional nurses, staff nurses, and auxiliary nurses. They all have different scopes of practice. So my focus groups were with RNs, registered nurses, and they were divided. It was only registered nurses, only staff nurses, and only auxiliary nurses because of their scope of practice. And I also conduct the focus groups at night when the night staff was working. And my data analysis was doing NCT analysis approach that was part of their Atlas TI, that's a qualitative data analysis software program, and these 2 works very nice together. 3 themes emerged of my data analysis, and I'm only going to discuss the one theme, and this theme had 3 categories, and with subcategories were identified. The theme that I'm going to do is the acknowledgement of patient outreach service in a team to obtain quality care. Now, the category that was identified as outreach as an essential in delivering care to at-risk patients, and the 2 subcategories were viewing of the positive outcomes, quality of patient care, patient satisfaction as essential, and knowledge about patients' health conditions. And during the focus group discussions, participants strongly expressed that the outreach nurse was an expert in our field, and when they called us, we guided them, we empowered them, and was helpful for them to in caring for the deteriorating patient. Participants also indicated the positive aspects that outreach contributed to them, in the sense that they found self-fulfillment when we helped them with their work. Problems with the patient was solved more quickly, and there was a strong agreement amongst these participants that the outreach service was a good service, and also patients recovered more quickly. As I know out of my head, I didn't prepare it. Before we started outreach, our code blues, or our patients that are in the wards, were very high. And this, after the outreach reach system was implemented, our arresting of patients decreased with 50%. So the patients, normally we had about 20 to 30 arrests in the wards, and it decreased to 1 to 2 patient arresting in the wards. So the outreach was a good system. And then also the participants indicated that we empowered them. We showed them what to do, what to look for, and this was also a part of your natural rewarding of the patient. The next category was assistance and guidance received from the patient outreach, and the subcategories were management of the modified early warning support, the support of nurses who ask for assistance, and teamwork is a critical component of health. Now, the management of the modified early warning system, the nurses use this muse as a cue for them to trigger us when to call us, and that is part of your behavior focused strategy. So they use the cue to change their behavior to act as it. So it worked very good for the patient. Patients patient quality care improved through that. And then also the nurses mentioned that it helped them to, when we assisted them for the patient, with the patient that is at risk of deterioration, they see the outreach system as a safety net. So that created the work environment in a more enjoyable environment that forms parts of your natural rewarding system. And then also teamwork. If you don't work as a team, if the ward nurses don't call the outreach sister, the experts, then teamwork is not good. But eventually, after the 15 years that I was working in the outreach department, there was a huge increase of teamwork that showed, and that helped the nurses that they feel very positive about their work environment. And the third category that was there was challenges in calling out the patient outreach expert and the role of the ward nurse as part of the team, and then a need for outreach expert to facilitate a positive outcome of a deteriorating patient. So some of the participants mentioned that some of the other nurses miscalculated the muse, and then we as the outreach team will come and show them how to do the muse, show them where they miscalculated it, and they also experience it as a positive way in empowering their knowledge as an empowerment. And also the nurses were also empowered. They knew when you come and do your rounds and show them, please look out for this type of thing. Look out for this with the patient specific, that's patient specific. So they were empowered through that. And then also they felt that outreach was a very essential for the quality care that patients needed to be doing. So they felt very positive about that. And then conclude, what the findings also indicated is that the nurses need to focus on the motivation of delivering a quality care. They need further training in the muse and outreach to empower them. And they also need to be confident in their knowledge about their patients, and they should have the expertise to call the outreach system. And they also found the attitude, a positive attitude to the outreach of this. So it became evident that the nurses used all three categories of self-leadership, namely the behavior-focused leadership, the natural reward system, and the constructive reward systems in treating the patient, in nursing the patient in the care. So that's just my list of references, and is any questions?
Can you hear me, Carine? Dr. Prinsloo? Hello? Hello, Dr. Prinsloo, are you able to hear me? Are you able to hear me, Dr. Prinsloo?
Okay, now I think, can you hear me now?
Yes.
Now I can hear you.
Unfortunately, I'm being blocked off from unmuting myself, apparently. That was an extremely informative presentation. I didn't know so much went into how nurses at work, how they are affected. I mean, it's all goodness because they are our main point of contact as far as healthcare is concerned. Are there any questions that can be asked for Dr. Prinsloo at this time? It would
Dr.
appear
Prinsloo?
not. Oh.
Now, I've got a question. Was there any difference in, you said there was 3 categories of nurses involved, the auxiliary, the enrolled, and the a registered nurse. Was there any difference in their behavior, in how they're seeing self-leadership?
The staff, some of the staff nurses was a bit hesitant in their knowledge because they were sometimes, to empower them, they had to do doctor's rounds. That was, and then they were sometimes scared to show their knowledge and be assertive in the doctor's rounds, with the doctor's rounds. But otherwise, their behavior, you know, the auxiliary nurses, they loved it because sometimes the registered nurse is busy and then they can't report that this patient's observation needs the outreach sister to be called. And then they just call us. They didn't wait for the registered nurse to finish with the task because they realized what is the urgency to call the outreach sister. And so they was empowered it, because if you did the rounds, you talk to them and say to them, you must look at this patient's urine output, check it, be aware that this could be a problem for the patient. So that empowered them. And also one thing I think it's a global problem with nurses is that they don't count respiration. And that's very important that's one of your first signs that the patient is deteriorating, is your respiration count. And this is one of those markers that I expressed on the auxiliary nurses, because the auxiliary nurses is the nurses that do the vital observations in the hospital, and they are the least qualified nurses. So that's very important thing, and they were so, if they could see that the patient is deteriorating because of his respiration rate and stuff. So that was enhancement, but overly they were the same self-leadership behavior and strategies they used.
Thank you very much, Dr. Prinsloo.
Are there any further questions for Dr. Prinsloo at this time? Any burning questions that we may have? No, well, that seems fine. Well, thank you so much for, as I said, such an informative presentation.